Ladies and gentlemen, dear colleagues, dear friends, I would like to welcome you to this ESCMID extraordinary webinar on professional affairs about clinical microbiologists and infectious disease during the turmoil of COVID-19. This is an extraordinary webinar because we all know that you are very busy for the last year with your patient, with viral testing. And here today, you will spend 2 hours with us. And I find it extraordinary that you will be available. This is also an extraordinary webinar because for the first time, we will not talk about the virus, we will not talk about your patient, no treatment, no sequences. We will talk only about you. You are the professional, clinical microbiologist, infectious disease, infection control, etc., trainees, senior, all of you who work a lot during the last year. You struggled with diagnostic, you struggled with patients, and then today we will speak about you. How was it, especially during the first wave, and a little bit about the second wave, but also new topics we never talk about, like anxiety, depression, your mental health, your resilience. How did you feel? How do you feel, etc. And I'm very glad as ESCMID Professional Affairs Officer. Although I'm professor in clinical microbiology, I'm a member of the executive committee of ESCMID, and I tried to have this webinar because I think this is important for you. So let me introduce the program rapidly. So during the first hour, we will have the results of surveys done between trainees, seniors from one country to another. And then during second hours, we invited extraordinary speakers because they are not EM, CM, nor ID, but they are specialized of what we want to hear. That means mental health, psychology, and they are well welcome in our ESCMID webinar. So before starting, I will introduce I will introduce my co-chair, Valentin Schweitzer. So Valentin, would you like to introduce yourself?
Yes, thank you, Emmanuel. So my name is Valentin Schweitzer, and I'm the current president of the Trainee Association of ESCMID, also known as TAE. And I'm a third-year trainee in clinical microbiology from the University Medical Center Utrecht. And I'm co-chairing today with Emmanuel this session. Really looking forward to it.
Well, thank you, Valentin. Just practical things. You can see down your screen a question and answer button. So we'll have each talk will be during 15 minutes, and then we'll have 5 minutes questions. So you may ask your question using this button. You write your question, and then at the end, Valentin and I will have a look at the question, and the question will be asked to the speaker. Of course, if there are more questions than during 5 minutes, then the question will remain on the screen, and then the speakers can answer a little bit later to your question. So don't feel shy to ask questions, but also don't worry if the question is not asked during these 5 minutes. So I think now we can start, and I'm very happy to introduce the first speaker. So the first speaker is Shamsu Chimen. She was in the trainee association of ESCMID during 3 years, a member of the steering committee, but now she got her diploma and now she joined a new group in both Germany and Netherlands for a PhD. And so she will introduce her talk on how much of practice differed from one place to another. Please, Shansu, you can share your screen. Is it okay with you?
Yes. Is it okay now? Can you see my presentation?
No, we don't see it. Maybe someone has to clean the screen. Hope we have ESCMID office helping us, because we don't see the screen, but maybe the screen is occupied by some of the slides. Can we do something? Can we solve that? This is nice.
Can you see it now?
Yes. So if you can put it full screen. Okay. Yeah, perfect. Please, the floor is yours.
Yeah, sorry for this technical issue. Good afternoon, everyone, and thank you very much for this kind introduction, Emmanuel. And today I'm going to talk about the results of our expert opinion questionnaire, which was endorsed by ATAF, Emerging Infection Task Force of ESCMID, and the Multidisciplinary Joint Committee in Infection Control of UMs. And when we conducted this questionnaire, I was working at the American Hospital in Istanbul, Turkey. But as Emmanuel mentioned, now I'm doing a joint PhD in Germany and in the Netherlands. And I would like to start by making a few remarks concerning the aim of this questionnaire. And as we are going through the greatest public health challenge of our times, which named COVID-19 pandemic, we wondered, as clinicians, I mean, with conducting this questionnaire, we wondered the situation and the first response of the world to this unexpected pandemic, and also describing the change in treatment choices, and by an update by the second round of our questionnaire, which the results that I will share with you maybe in another webinar. And to be able to answer this question, we conducted a cross-sectional online questionnaire, and we tried to reach 3 representatives from 56 different countries from Europe, but also out of Europe. And why we called this questionnaire an expert opinion questionnaire, because we tried to reach the figures of the countries, I mean, in 4 different disciplines, from infectious diseases and clinical microbiology, infection control, and intensive care unit disciplines. And the questionnaire was open from the 6th of July till the 28th of August in 2020. And we also sent periodic reminders to our responders and to be able to reach the best rate, the best response rate. And this 23-item online questionnaire was divided in 3 sections, and that are named infection control measures and diagnosis and management, and also treatment options. And after closing the questionnaire, we tried to clarify the discrepancies among the representatives in the countries. But then we had to, after reaching our colleagues to solve this problem, we had to accept that the answers were also different from each other, also from the same country. So I would like to highlight that during this talk, what I will share during this talk, they are not standing for the unique facts of countries, or they are not statistically significant. But what I want to achieve with this talk, to remind you of the first days, I mean, the first wave of the pandemic and the issues that we faced, and also create a picture of the situation of the world at the very beginning stage of this pandemic. And I mentioned that we tried to reach 56 countries, and then we could cover 36 of them, and we reached 55 representatives from these different 36 countries. And unfortunately, from most of the countries, we only have one respondent. And if I start with the infection control measures, and it was quite a hot topic. I mean, which kind of mask should be used in which clinical situation? I mean, the surgical mask or respirators, which are named FFP2, FFP3, and N95. And we created some clinical situations for our responders. For example, just for the routine patient care, I mean, your patient is not receiving any oxygen support, or your patient is receiving an oxygen support with nasal cannula or simple face mask, or receiving nebulizer treatment, or you are examining the nasopharyngeal sampling, or during the tracheostomy or intubation or extubation, or you are examining an intubated patient. What were you doing with this kind of clinical situations, we asked. And in 16 countries, they were using respirators only for the patients who were receiving nebulizer treatment, or while performing nasopharyngeal sampling, tracheostomy, or intubation and extubation. And here is the list of the countries. And in Mexico, Russia, Israel, Pakistan, South Korea, and the listed countries from Europe that you see here, they were using respirators, let's say always, except for the routine patient care. For all the other cases, they were always using respirators. And in 3 countries, in Croatia, Estonia, and China, they were always using respirators. I mean, FFP2, 3, and N95 for all kinds of patient contact. As I told you before, there were also some differences also in the same country, in Italy, Spain, and Portugal. And our colleagues from different hospitals, they answered this question that yes, they were always using respirators. At the same time, the other colleagues from the same country, they were only using it for certain clinical issues. And by the time that, since we started hospitalizing COVID-19 patients, at the same time, we started to transfer our patients to the intensive care units. And we created 3 different scenarios to ask our participants. And you have a patient and you have to transfer your patient to the ICU. And in the first 2 scenarios, and your patient needs an oxygen support with simple mask or nasal cannula, or you had to intubate your patient in the ward, and then you have to transfer the patient. And I will share the answers for the intubated patients with you. And most of the colleagues in they were using the HEPA filters to place on the ventilators, more than half of the countries. And then 6 of them, they were using covering the airway with hydrophobic filter. And in 6 of them, they were either using the hydrophobic filter or HEPA filters to place the ventilators. And interestingly, in Italy, in the Netherlands, Latvia, Canada, and Peru, China, and Thailand, they were also covering the intubated patients totally with a clear plastic cover, while they were transferring them from the normal wards to general wards to the ICUs. And in Germany, Belgium, Cyprus, Macedonia, and Russia, they were only making their patients wear a surgical mask and then transfer. And if we move on to the diagnosis, This issue was discussed a lot, and we were also wondering what was happening in the countries. I mean, there were lots of reports regarding the COVID-19 cases, also the death numbers due to COVID-19 disease, and reported to the national authorities or the WHO. And we asked our colleagues, and how was your country reporting the COVID-19 cases? And in Belgium, Switzerland, France, Peru, Pakistan, and Mexico, they were not only reporting the definite cases, but also probable cases, which means that the PCR result was not positive. PCR result for SARS-CoV-2 was not mandatory. And even for the deaths, I mean, reporting the deaths, only in Belgium, the probable COVID-19 cases were being reported to the authorities or WHO as deaths due to COVID-19. And the other question that we faced a lot, or the issue, I might say, also from my clinical practice, my own clinical practice, we were having some patients with negative PCR result for SARS-CoV-2, but the patient story and the clinical findings, also the radiological findings, they were certainly pointing to COVID-19 disease. And we asked our colleagues, and if they were using X-ray or CT to back up their diagnosis in clinics. And in Sweden, Hungary, Turkey, Italy, Albania, Latvia, Serbia, France, Russia, and Mexico, they were mostly using, and they answered usually or even almost and always CT. They were preferring CT to X-ray. And if I move on to the treatment options, hydroxychloroquine, we could say that this is the mostly debated, discussed drug since the beginning of the pandemic, and maybe even nowadays. And it was recommended in Russia as a pre-exposure prophylaxis for healthcare workers, and also in Turkey. It was recommended as post-exposure prophylaxis for healthcare workers. Despite the fact that it was only recommended in 2 countries as prophylaxis, with or without azithromycin, hydroxychloroquine was one of the most commonly used drugs at the beginning of the pandemic, with lopinavir, ritonavir, and remdesivir. And as immunomodulator agents, and corticosteroids was mostly commonly used one, and also interleukin blockers. And doesn't have the same repetition maybe like hydroxychloroquine, but favipiravir was also questioned a lot. And in Hungary, Turkey, Poland, Portugal, Thailand, and South Korea, it was also used for the treatment of COVID-19 patients. And the convalescent plasma, and it was not shown that it is really effective in the course of COVID-19 patients. And in mostly in European countries, it was only used in clinical trials. But in Hungary, Turkey, Italy, Israel, Croatia, Macedonia, Bulgaria, Russia, and China, it was also used in routine patient care. And the only treatment option was not used in the routine patient care, but only clinical trials. It was mesenchymal stem cell treatment, and it was conducted in clinical trials in Italy, Spain, Belgium, France, Hungary, Turkey, Bulgaria, and South Korea. And I would like to conclude my talk by remarking the diverse response to this pandemic, and not only among countries, but also within countries. And as I mentioned at the beginning of my talk, that this is the greatest public health challenge of our times. But I think that, as we see from this questionnaire, that maybe we can use this challenge and turn into as an opportunity to be well prepared, maybe for the upcoming public health challenge or outbreaks, by learning from our mistakes. I mean, conducting high qualified clinical trials on time to search for the best treatment, I mean, against these pathogens, and also conducting or establishing international guidelines on time, and establishing national guidelines on time, and also try to implement these national guidelines at local levels. Because what we saw from this questionnaire, that the response to this unexpected pandemic was also diverse in the same country. And after more than 1 year, we have such a well-established guidelines regarding the diagnosis and infection control measures and treatment options, but still we do not have a consensus on treatment options. And regarding this, we again ask our responders, and what has changed in the COVID-19 treatment during the last 9 months in your country? And actually now we are still collecting the answers for the second part of our survey. And I would like to thank to our survey group, Nick Beeching from the UK, Önder Gönül and Şiyan Keske from Turkey, Rebecca Loeffenberg from Germany, Eskil Petterson from Denmark, and Nicola Petrosillo from Italy. And I would also like to take the opportunity to thank all the responders from 36 different countries. And I would also like to thank you for your attention. I think we still might have room for questions and maybe your comments. Thank you very much.
Well, thank you very much, Ansu. That was very interesting. We don't have any written questions, but of course, we may have some questions from the board. And so I may start with one question. You say you will have more answers on the second and third wave, probably. That was very interesting to see that when we don't have evidence, that means at the beginning, I mean, we are lost. And that's so interesting to show how, although ID or CM, they are trained similarly, how they respond differently to this. So you clearly say we need to have rapidly guidelines and share things. I would say, yeah, we need to share it quite rapidly and not only with publications, but also in talking and discussing. That's what we try to do. Are there any questions among you? Oh, yes, there is a question. Have you had a chance to look at laboratory facilities in each area? Yeah, of course. You've seen in some countries, we do not say that, and you didn't say in some countries they didn't have any mask, but of course the use will depend on your resources. So can you answer the question?
Yeah, regarding the laboratory facilities, we asked the question regarding if they also had the anticore or antigen-based tests, rapid tests. But then at this stage of this pandemic, I did not find it so relevant to share it here, because now all the countries can reach that. But we asked the question regarding the personal PPE efficiency. I mean, were they enough? And at the beginning of the pandemic, and while our responders were answering the questions, also the healthcare workers, I mean, number of nurses and ICU beds, but it was totally very, very different from each other. I mean, regarding the numbers, it was not possible to create a common answer from that. But regarding the laboratory facilities for maybe PCR, no, we did not have the chance to ask or evaluate this issue.
Yeah, thank you. So please go on with your questionnaire. That will be very interesting at the end.
Thank you very much.
Any other question? Okay, so now we'll move to the second speaker, and I will let my co-chair to introduce them.
Yeah, so it's my pleasure to introduce the next speakers, which will be Bologna Mave Vondicar and Alejandro Martin Piro. They will speak about the role of healthcare workers during the COVID-19 pandemic. Bologna, she works at the University of Ljubljana, and she was also previously a TAE member and also a TAE president for 2 years. She is also currently a member of the Professional Affairs Subcommittee and works as a clinical microbiology specialist, also in the Institute of Medical Microbiology and Immunology, and as an assistant professor of the University of Ljubljana. Alejandro, he is an infectious disease specialist based in Madrid, Spain. He holds a PhD in medicine and infectious diseases, and he is currently working in the emergency department and also in the clinical trial department of the University of Madrid. So please, the floor is yours.
Okay, I'm going to share my presentation. Can you see it? I think so. Okay. First of all, thank you very much to Emanuela and Valentin for joining to this workshop. I think it's a pleasure to share our findings in this issue. I think the COVID was a very difficult situation, and for ID and CM specialists was very severe condition, and we proposed to Professional Affairs Subcommittee to do a survey about this situation, and this is our results. We started this survey between September and October of 2020. We have a total of almost 300 patient colleagues from all around the world. Later we are going to see the countries. Most of the people who answered the survey was in a young situation between 24 to 45 age of old, and the gender was 50%. As you can see here, almost all patients were, colleagues were from Europe, although we have people from all around the world with Asia, America, Africa, all of countries, mainly from Europe. We asked about the profession of these responders. They were mostly physicians in almost 90%, although we have only a small proportion of nurses. There were only 1%, and microbiologists only have 4%. About the specialty, we have 43% of infectious diseases specialists and 31% of clinical microbiologists. We have to note that a lot of colleagues were sharing several specialty of CM, AT, ICP. So there were a mix of all specialty in the answers. Into the questionnaire, our first question were how was their satisfaction about the specialty they are working before COVID-19, because we thought that it was very important to know how was the starting point for this specialist. And we have a very good situation. I think an average of 8 points from 10 is a very good satisfaction level for these healthcare workers. The hospital in which they are working, it is normally a big hospital with more than 500 beds in most of them, and the majority of patients that they received were from their own ER. So the hospital in which the responder was working received directly the patient. They don't have a patient from other hospital or from other facilities. About the overwhelming situation in their hospital, the average was, say, 6 points. I think it's a very very high. Almost we can think this is a moderately answer, but we have to remember that 0 is not overwhelming situation and 10 is a very overwhelming situation, and almost 25% of them consider that they were in a very high overwhelming situation. The most of the hospital need to increase number of ICU beds from more than 100%. This is the double of beds that they have before COVID-19. And in a majority of hospital, the number of beds occupied by patients with COVID-19 were in a very high situation, from more than 40% of beds occupied by this disease. Then directly attended by the responder, this is for medical staff, not for clinical microbiology, of course, and they have to attend directly to 0 to 10 patients in almost the 30% of people who answer the question. But it's very, very important to note that more than 40 responders have to attend directly to more than 50 patients by day. So this is a very important number. Almost, although they were not the majority, I think it's crazy to receive more than 50% by day. Prior to the pandemic, almost 50% of the responder have to have direct responsibility for the management of the patient, but in the COVID-19, they have to create new teams to attend all the patient. And you can see here that in 30% of 70% of cases, all specialists, all medical specialists have to attend the COVID-19, independently the previous specialists. The most of hospitals have to develop new protocol from their own institution and not from the department. And this is only one of each 10 hospital, but majority of the hospital have a protocol from the institution. During the pandemic, this is the condition for laboratories. I'm going to leave the word to Plona.
Okay, thank you, Alejandra, and good afternoon to everybody. I will take over for just a couple of slides now and ask Alejandra to continue with sharing the presentation so that we don't lose too much time. So the same way hospitals had to adapt to these new circumstances, major adaptations were necessary also in the laboratories. And among 290 respondents, 126 were directly involved in the laboratory procedure of COVID-19 testing, but many answers are actually from all the participants. Almost a half of participants reported laboratory capacities being overwhelmed with the samples, at least at specific moments, and 36% had such a problem from the beginning, and only 17% reported having no problem to cope with the number of samples received in the laboratory. Regarding organizational changes, here were multiple answers were possible here. Majority reported increased working hours, and they recruited additional technicians, not so much additional doctors. They also introduced 24/7 working hours, and they introduced some relocation of staff. Next question was about the turnaround time for SARS-CoV-2 results, and the most common answer was between 12 to 24 hours. Interestingly, quite a high number of respondents also replied that they needed 4 to 8 hours for SARS coronavirus results, but nearly 20% of participants also reported this turnaround time being more than 24 hours. Overall, 89% of the participants working in the labs reported that they felt time pressure from their colleagues, from clinicians, to provide the results faster. But this was the first wave when there was shortage of personal protective equipment in many hospitals, and it was much more difficult for the clinicians to work with COVID patients. So what about the extra working hours? As you can see, these are the answers from all the participants, not the laboratory workers. Most of the participants replied that their working time was much longer than before COVID. And to the specific question, how much longer was this working time? Around 70 respondents replied that more than 20 extra hours per week. But interestingly, almost the same number of participants also replied that their working time did not change at all. The general feeling of being overwhelmed was pretty present during the first wave. You can see the average was 6.7, but many participants scored it with 10. So was the feeling of being very useful or even extremely useful. As you can see, average was 8.1, and again, a lot of respondents with score 10. So healthcare workers also felt that general population valued their work in a very positive way, and institution management also valued their work, although with slightly lower ratings, 7.6 compared to 7.0. And the institution support to healthcare workers during the first wave was somewhere in the middle. The average was 6.5. Maybe a little bit to the positive side, and so was the rating of the organization in managing the COVID-19 during the first wave. And I'll just give word back to Alejandro to continue with the presentation.
Thank you, Polona. We asked also about the PPE availability, and it's very interesting that more than 50% of hospital, of institution of the people that answered the questionnaire had a shortage of PPE at a specific moment, and more hard situation, this 8 or 1%, this 10% almost, that they had to adapt the materials to create new PPE, or that have to attend patient without PPE at any moment of the first wave. And also one question is about the scientific work about the COVID-19 during the first wave, about all the publication that we receive every day, and how the people stay updated. And the most of the responder read directly the papers, the scientific journals. However, we have 20% of people that maintain the update by webinars or virtual conference, social media protocols, papers, not any other papers, or by other colleagues. The scientific work rate for these publications was an average of 6.5. I think it's a moderate rate, because all we know that the difficult for publish any result, and it's a very good situation. And the people rate the journal's role about during the COVID-19 in 6.8. Only 12% of healthcare workers that answered the survey was infected by SARS-CoV-2, and 1% that we can't know. And the symptoms, the severity of the infection was low in the most of cases, and most of the people infected come back to the previous health status after the infection. And finally, the personal life of the responder, they felt that they work during the first wave affected directly to their personal life in an average of 7.2, and they perceived that their personal life was worse than before, with a situation that 3.6. Most of the healthcare workers that answer the survey stay at home with their relatives. However, 15% have to move to other houses to avoid infection between relatives. The resting time, we think is important in a situation of overwhelming work. It's important to know how is the resting time, the quality and the quantity of resting time. The workers lost the resting time with an average of 3.4 compared with previous the pandemic, and the quality of this resting time was also worse than before with an average of 3.2. In conclusion, during the first wave of this pandemic, hospitals were moderately overwhelmed. ICU needed to be increased almost in double number of beds. Almost all ID-related medical staff had to attend COVID-19 patients, and almost all microbiology-related staff had to do SARS-CoV-2-related issues, and they needed to adapt the organization of their department to the new reality. Both specialist areas felt highly overwhelmed during the first wave, and they felt their work was very useful. Both specialists, and this is very important, felt highly overwhelmed during first wave, and they felt their work was very useful. And they feel that the management institution board of their facilities support moderately their work, but they perceive that the general population valued highly their work. More than half of healthcare workers had shortage of PPE. Infections were mild between healthcare workers, and they recovered their previous health status. Infections were mild and healthcare workers recovered their previous health status. Sorry, this is the same. And the work condition affect intensively to their personal life, and they felt that they lost personal life quality than before of the pandemic situation, with a shorter and poorer resting time. Thank you very much for your attention.
Thank you for this interesting presentation. Are there any questions from the audience? I think there is one just coming in. Did you look at regional differences in the preparedness and response?
We also have to analyze this difference, but the thing is that we have, as you can see in the presentation, we have a lot of countries with only one or two answers. So probably we have to do this analysis only with the mostly responder countries.
Okay. I also have a question myself. Maybe we will get some more questions from the audience. I was wondering, did you also ask people about the shortage of testing regions? Because it was now focused on testing capacity, but I know, for instance, in the Netherlands, the testing capacity was not really the problem, but we were just short on testing material. Do we have any information about this?
No, in our questionnaire, we don't ask this question, but I think it's very interesting.
I think the shortage was felt in a lot of places, in a lot of countries. But yeah, it was not included in the questionnaire, unfortunately.
Okay.
Do you want to do the questionnaire also for the second and third wave? Because the answers might be different also. What do you think? Because you felt it also, you left it.
Yeah, we think we have to do a second wave of the questionnaire to compare the situation of the first wave. I think the first wave was horrible, and the second and third and fourth, and fifth in Spain, for example, I think the situation is very different, and probably the role of the healthcare worker are totally changed.
And in Slovenia as well, was it different between the different waves?
We had a very mild first wave and a huge second wave, and I think and what would be the same in all healthcare workers is probably the exhaustion, you know, because we were under adrenaline rush during the first wave, and if this thing's going so many months on and on and on, you know, it would be really interesting to see the answer this time.
And for instance, are there more healthcare workers in your hospital?
In my hospital, for example, no. We have more during the second wave. Yes, we have more healthcare workers, but in Madrid they create a COVID hospital, and they send the new contracts to this hospital.
And regarding the type of shortage in healthcare workers, do you know where the definite pain points are? Because I think in the Netherlands, it's mostly ICU nurses who are really on shortage. Do you have the same experience?
Yeah, in Spain today, for example, today is the World Day of Nurse, and they estimate that in Spain there is a shortage of 30,000 of nurses around the country. The problem here in Spain is that they have a very poor contract, and the salary is lower than other countries. So nurses go out to other countries in Europe.
I think we have a last question from Stefan.
Yeah, just wondering, I think one of the strengths of your questionnaire is that you have so many countries represented. And so I was wondering, could you maybe have correlations with, say, infection rates at the time, or correlation with health budgets in the different countries, to see whether that has any relationship with your results?
Okay. Great, thank you.
I think we need to move to the next presentation, and the next presentation will be done by the ID and CM trainees. And I would like to introduce first Kevin Bouier. So Kevin is infectious disease at the University Hospital of Besançon in France, and is working in infectious disease, but is also spending times with national societies and international cooperation. And so I think, Kevin, you will start, and then Valentin, my co-chair, will follow. So please, can you share your screen? And you may start.
Yes, thank you very much. It's a great pleasure for me to be here and to present our work. And I would like to thank TAE to permit me to present this work. And I would like so to thank the network of young French infectious disease specialists to present this. So consequences of COVID-19 was well known on healthcare workers, with anxiety, safety, and increase in workload. But there are few data on trainees, and surprisingly, there are a lot of data in surgical and anesthesia trainees, but few in infectious disease and clinical microbiology trainees. So we developed a survey with a TAE committee and a young scientist infectious disease. And we directly sent this survey by mail to all the members of the TAE via 3 different pathways. And this survey was available online from 4 September to 6 December. The survey contains contains 4 different sections with demographic characteristics, role of ID and CM trainees, impact on training, and perception and feeling. We compared between southern, eastern European countries and northern and western countries. So 235 trainees participated to this survey with a mean age of 31 years old. There were 56% of infectious diseases trainees and 38 clinical microbiology. Mostly there is first, second, and third years of training. Trainees from 22 countries responded to the survey, including 63 trainees from France, 21 from Belgium, and 23 from UK, the three main countries that participated to the survey, and some countries has only one trainee who responded to this survey. 95% of the participants had COVID-19 activity, mainly care for hospitalized patients, research activities, and diagnostic procedure. 91% interrupted their training, conference and congresses for 61%, research for 40%, clinical and laboratory rotation for 40%, clinical activity, teaching, university training, and clinical consultation and laboratory for around 20%. The most difficult things to manage during the first wave of the pandemic was rapidly changing guidance for 55% of participants, distance from family and friends, lack of communication, lack of guidance, and lack of data on COVID-19, related probably to the difficulty of managing an emerging disease for which little information is known. 20% find difficult to work in PPE and keeping up with emerging evidence. Uh, 80% of trainees felt useful in managing the crisis. However, 80% felt more stressed and more tired during the pandemic than during another internship. And around 80% were afraid of infecting people around them. When we compared the Southern and Eastern European countries and Western Northern European countries, we showed that trainees who worked in Southern and Eastern countries regrets their choice to be a healthcare professional for 18% versus 6% for other European countries. And moreover, they were more often afraid of being infected with SARS-CoV-2 and felt more stressed and felt less useful in managing the crisis. So majority of clinical microbiology and infectious disease trainees participated in clinical and research activities during COVID-19 pandemic, and 90% of trainees felt helpful in managing the pandemic. The negative points of the pandemic were increased workload, irregular shift patterns, more stress, and they were more tired, and they have to interrupt their training, and they have like a lot of information on communication between different hospitals and between different countries, and it was a problem. I left my place to Valentin to continue the presentation.
Yes, thank you very much, Kevin. I have a really short follow-up presentation, and maybe we can do questions after this presentation. So I want to briefly introduce the TAE forum, which is a way to connect trainees. So as most of you probably know, the COVID pandemic resulted in more and more isolation of ID and CM trainees. And one of the things that came up from the survey that Kevin presented was that it would be important to increase the interconnectedness of between trainees in ID and CM, with the ultimate goal to share experiences, local practices, and also discuss new research articles and emerging other relevant topics such as vaccination, changes in treatment, etc. And so in part of this, we had a new idea to launch a forum for international ID and clinical microbiology trainees. So in response to this, we launched the TAE forum using the Slack platform. And Slack is a very easy to use and free platform where you can create different types of channels, which you can see on the left side, so general ESCMID research channels, and people are able to start conversations and discussions within these channels. And to test this TAE forum, we created a pilot period of 3 months, which lasted between February till May. And for this pilot, we invited the national representatives of the TAE network, which were 31 representatives in total. And we also performed a pre and post pilot survey to pick their brains for ideas and opinions about our TAE forum. So I have some very short a few results. So when we asked the respondents what they thought about the statements, I want to start local projects with input from trainees from other countries, then almost 90% of the respondents either somewhat agreed or completely agreed, which was similar to the statement, I want to be able to talk to trainees in ID and CM from other countries directly. So there obviously is a need for a platform like this. Also, most of the respondents thought that Slack might be an appropriate platform to organize the forum. When we asked these representatives, how do you suggest that we use this TAE forum? I have a few quotes. So one said to share experiences, share events, ask questions and doubts about clinical situations. Another quote is to discuss situations in their countries and share their own experiences. Another one said as a mean of an academic interaction and hopefully form international collaborations. So during the pilot phase, we actually had quite some discussions on various topics, and the topics that came up naturally were, for instance, the COVID situation and experiences in each country. It was very interesting to hear about this and their own experiences. We also discussed COVID vaccination strategies in each country, how variant tracking in each country is performed, and we also briefly discussed the UEMS medical microbiology pilot exam. So it's really a place where people can discuss things that are relevant for them. So the future plans for the TAE forum are to introduce regular content. This was also something that they suggested at the post pilot surveys. And regular content could be, for instance, moderated clinical case discussions, journal clubs, and also meetings. And the next step, if everything is finished successful, would be to open the forum to all young scientist members from ESCMID. So please stay tuned for more news on this. Then now we have
yeah. Thank you very much. So your talk is open for discussion. There is no question so far, so maybe I will ask one first to Kevin. That's very interesting how you compared countries. So what do you think you will do with this? Or is it a way of improving the work in some places or thinking differently? What do you think of that?
It's a good question because we choose to compare these countries because in southern and eastern countries, we consider that there is more middle income countries, and maybe there is an impact on the management and COVID-19 and on healthcare workers, so on trainees. But I don't think it's the only answer to explain these differences. The other difference between these countries was there were more CM trainees who were answered to the survey in eastern and southern countries. So I think comparison is difficult, but I think it's interesting to present this. There are other differences between financial compensation in trainees between different countries. And this is another point, but I don't have time to present all the results.
Yeah, very interesting. Do you have any question among the speakers? So I may go on. One of the points you say, which is really impressive, is that more than 90% say they had to interrupt their training. And does it mean that the other specialties, they did not share the workload? I mean, the cardiologists and so on. Did they help? Were they of any help?
Yeah.
In different countries. I mean, it might be different.
Yes. Yes, we didn't ask this question. In my hospital, not all trainees help for COVID-19 activities, and it's mainly infectious disease and clinical microbiology. And the other problems that other trainees help for 1 week, 2 weeks, our infectious disease and clinical microbiology, it's all the time, all the wave, during all the waves. So I think it's different, but we didn't
ask.
Yes, ask this question. Yeah. Sorry, thank you.
Yeah, and Valentin, maybe for the training, I mean, theoretical training, can we do something, I mean, all together to improve this?
Yeah, I think that's an important point. I think that the first step would be what part of your training did you actually miss, and how much delay did actually result from the COVID pandemic, and then move forward from here. That's actually the way we are doing it in the Netherlands. We are making an inventory how much delay actually is present, and then we have to take action from this.
So are there other questions? Well, if not, I think we can move to the next speaker, and Valentin will introduce.
Yes, I'm very happy to introduce Olga Vedenskaya, and please excuse me if I pronounce your name not correctly. But we are really happy that you are able to join us as a speaker on a very important topic, I think, which is the mental health of PhD students and medical trainees, embracing failure and maintaining self-care. And you are actually also an MD yourself. You're originally from Moscow, Russia, and you worked on your MD thesis in translational medicine and mass spectrometry in the USA. So actually quite a different topic. And you are currently involved in the Dragonfly mental health project, which is also very interesting. And I'm not sure whether you will talk about this during your presentation, but otherwise maybe afterwards we can hear something about this. So please, the floor is yours.
Thank you so much. And first of all, yes, I am an MD myself, and then I also, okay, I'll share my slides and then we'll talk about it. I have to say that It's extremely difficult now for me to start talking about the mental health, because we've been just talking about all the struggles medical doctors and trainees went through. And I was hoping that I wouldn't be the first one to do that. And however, I am, and I'm very glad that there will be another speaker after me who talk about the anxiety and depression as well. That's why I'm not covering it today in my presentation. So yes, we as Dragonfly are extremely pleased that we were invited to talk about mental health of PhD students and medical trainees. And we also talk about, I mean, mostly I'll talk about the students and trainees, but then we'll also we'll have a possibility to discuss something about the medical professionals as well. We will talk about embracing failure and maintaining the self-care today. So as Valentin has already mentioned, I indeed have my MD, which I obtained from Moscow, and I also have obtained my PhD from Berlin. Both of it was done in translational medicine. And I'm currently working as a postdoc in Dresden in Germany, where we have organized, together with my colleagues, some mental health initiative devoted locally to some particular aspects of PhD life. PhD student life. We have also organized the Mental Health Collective in the Global Max Planck Society. And worldwide, we have organized the Dragonfly Mental Health, which is focusing on cultivating the excellent mental health in academics and like medical doctors and professional students worldwide. I will talk mostly about mental health during the pandemic. So of course, this talk was initially built for the students who are struggling from isolation. And I see today that the crowd is slightly different. Some of them, of course, some students are here with us, and some medical doctors who were in the battlefield are also with us. So what's different from our previous life? So initially, of course, this is the lack of physical contact with other family members, friends, and colleagues. Some of us tend to work from home. Some of us experience temporary unemployment. Some of us experience tremendous workload at the front line of the COVID fight. When it comes to trainees, we had to stop our wet lab, preliminary wet lab research activities. In general, it brings the whole uncertainty for the future, whether it's financially, health-wise, travels, or other plans. And of course, most of us had to deal with this homeschooling of children. So there is no chance it wouldn't affect us and our mental health. And there were some publications about the impact of psychological impact of quarantine measures. In this case, it was coronavirus. And there were 13 studies, and all of them confirmed that there was negative psychosocial outcome, such as depressive symptoms and anxiety, which will be talked about later. Then also anger, stress, post-traumatic stress, social isolation, loneliness, and stigmatization. And the conclusion was that definitely quarantine measures during serious coronavirus outbreaks have extensive negative consequences for mental health. What I'd like to tell you today, literally like a couple of slides to focus on, is this is a wonderful study ran by University College London during the 20 weeks of isolation. So these were mostly the people who were isolating, it's adults or young adults mostly. And here I would like to focus on the result of the study showing that depression by age groups is higher in the groups of people age 18 to 29. So here is basically mostly where our PhD students, master students, and professional students such as MD students and trainees are falling into this category. So they are the most vulnerable group compared to the people from older groups. And the same goes by anxiety. And here, why I'm bringing this up is that I hope that today with us, there are some faculty or maybe senior doctors, and I'd like you to see that these groups of people, people of age 18 to 29, they really need our support because they're the most struggling with this. In general, with the So this was the study based on the first wave, and of course we see that the people getting used to the situation, and the government sort of make sure that the things are getting taken care of, and in general the stressors are getting less with the growth of, so with the length of the wave, and life satisfaction grows. However, people are still worried about the unemployment, financial situation, some even about getting food and so on. What I would like to focus today on is what is happening to our body and mind. We all need to understand, and I'm pretty sure that today's crowd, I'm very happy, understand that mental health is not different from physical health. And we should be aware that there are triggers affecting the mental state. And we need to understand our anxiety responses and manage the stimuli that makes us anxious. That's why I'll briefly mention this parasympathetic and sympathetic system, which are responsible for our stress and anxiety response. Of course, all of you know about this. The thing is that we need to understand that it's not only applicable to our patients, but also applicable to us. And this is kind of transfer, which is really difficult sometimes to make. As you are aware, our sympathetic system is responsible for fight or flight response. And in case of acute stress, for example, how it was built evolutionary in case of when we see the predator in savanna, the response for our body is known. So we need to do something right now, such as fight or flight. This causes our sympathetic system to be on for a short time, and when the stress is gone, our parasympathetic system switches on, and this is the normal cycle. So in case of chronic stress, whether you are isolating or whether you are at the front line, or whether you are an essential worker who is not a medical doctor, the COVID-19 is there all the time. And so your body and your mind, they feel like you need to do something, whether it's fight or flight. But in case of COVID-19 global pandemic, nothing can be done globally by one person. And you cannot fight it globally, if we're speaking about it, or you cannot flight from it because there is no COVID-free space. This whole situation causes our sympathetic system to be on chronically. And that's why you're feeling anxious and agitated permanently. And it is really critical to manage the system in order to stay sane during this time. First of all, the symptoms which we experience are the following. For example, the chronic stress which we're dealing with, it causes our sleep to be disturbed, which causes this creates a nasty feedback cycle. So it's harder to handle the anxiety, you cannot sleep. Therefore, you're anxious, therefore you cannot sleep, and so on and so forth. So multiple resources suggest that while it's important to acknowledge that these feelings are reasonable, one should really try to practice guided relaxation to switch to parasympathetic response. And this is really, really helpful. I'm not sure what is the geographical background from our visitors today, from our listeners. So I'm coming, as you already know, from the Soviet Union. And of course, this whole guided relaxation and in general relaxation was never a thing there. So I was pretty skeptical when I tried it out, but it does really work. So I really strongly encourage you to work on it. Also, it's important to understand that our emotional control is impaired during the pandemic time, and therefore your body, so your body and mind are told to fight or flight. And of course, you tend to unleash on the closest people who are to you, like your close friends, colleagues, and family. So it's important to tell yourself every day that you're doing your part. Of course, you're doing your part if you are an essential worker. Of course, you're doing your part if you are fighting at the front line in the hospital. However, during the isolation time, when you're isolating, it's also important to tell yourself that you're doing your part. You're helping the workers to release the load on them. You're helping senior citizens who are under the larger impact. So you're doing your part, and it's important that you tell it to yourself. Of course, we all, or most of us, experience the loss of structure, so it's essential to create new structures independent on how your life was affected. It's really, really essential to take care of it. And we all tend to ruminate, and the more stressed and sleep deprived we are, we ruminate. So it's when our brain constantly thinks about one thing and you cannot switch the topic, you cannot get out of the thought in your head. So it's important to understand that the brain can only ruminate at one thing at a time. So you could try to switch the rumination subject using distractors. Some people tend to watch movies they have already seen. Some people tend to, I don't know, do something else. My trick is, this is what I would like you to also check out, is to start to describe yourself some pleasant picture. For example, here you see the flower field. So in case if you're ruminating and cannot really switch the topic, try to like look at the picture and tell yourself, I see the pink flower, I see 2 red flowers, I see poppy flowers, I see yellow flowers on the background. And by describing some pleasant picture, you'll help your brain to switch from the rumination subject, from the rumination topic. And that really helps. I also would encourage you to do so. So essentially, it's, the whole aim is to manage your environment, to minimize anxiety triggers and to maximize anti-anxiety experiences. And if we're talking about the resetting goals, redefining success and embracing failure, that's a whole different topic, of course. But what I'd like you to think, especially if you're experiencing this loss of structure or like loss of future plans, I think what is suggested is to think what is your actual goal now and how did your goals change through this year. So one is like getting vaccinated, for example, which was mentioned before today, or making sure that the people are getting vaccinated. So most likely 2 years ago, 1.5 years ago, you had completely different goals. So you should try to evaluate the evolution of your goals and think what is actually important. And what is important is to focus on your mental health. And if you're scared that if you focus on the mental health, it will lead to the decrease of your productivity, that has been proven wrong. So the more we focus on our mental health, the more our productivity when it comes to work increases. Again, work-wise, it's also essential to redefine your goals, which most likely were affected, especially when it comes to trainees, when it comes, as we have already discussed today, someone had to postpone their training, or to or for PhD students, it's also really difficult. So you need to redefine the goals with your supervisors and adjust your schedule. We cannot wait any longer to postpone the things for, okay, maybe in 2 weeks things will get different, maybe in extra 2 weeks things will get different. It's really essential that you redefine the goals and try to adjust to the new environment. And regarding failure, it was actually a difficult task to think about it, because especially now, the failure concept has changed, and we as a mental health initiative, as a mental health nonprofit, we're very happy to see that there are more and more publications embracing the failure. However, we do not encourage everyone to go outside and fail in everything. The point, in our opinion, is that the point is not to fail precisely. The point is to try new things when all things don't work. And this is extremely important. And in doing so, you'll hit on some new things that are successful to you. Essentially, failing sets you to a new path. And the failures you make, they contain within them the seeds of success, or the right path, if you can talk about, or the more fitting path to you. So this is when it comes to embracing failure, and I think this is, of course, very, very important when it comes, especially to the trainees and to the PhD students. Let's also talk a little bit about intentionally building new schedule or structure. However, it's extremely difficult with the regulations changing every other week, especially in some countries where they're more flexible about new schedule and new regulations. So it seems like we all have to readjust our schedule, or our daily schedule, or our weekly schedule, but I still strongly encourage you to have one. So we recommend to wake up at specific time and go to bed at specific time, to eat your meals roughly at the same time, And of course, as everyone would say, try to eat healthy food. I strongly recommend, even during the isolation, to still have to try to get your morning walks, or at least one walk a day. Like having an animal, of course, helps a lot, and it's difficult when we live alone to make ourselves to have some structure. And of course, try to set quality time with your family if you have one, to try to enjoy the activities together, such as karaoke or family yoga or watching series and singing. It all helps. Of course, it is more difficult for people who have to homeschool their children. There are some publications about how to try to arrange your schedule around it. And last but not the least, I really strongly encourage you to use the advantages of virtual communication with colleagues, so mentors, mentees, and coworkers. When it comes to work-related things, I would suggest informal coffee breaks with your lab or with your department. It will help you to still stay in touch with the people. And I love journal clubs. Some people don't really like it, but if it's informal and not so mandatory, then it can be a nice and pleasant activity. And I would also recommend you to schedule the regular online talks with your mentors and mentees, not once a month, but rather once a week when you have time and when they have time, because and not for the work progress, but rather for to letting your mentees know that they're taken care of and that you are there for them, and that they can rely on you. I would also recommend you to socialize with other scientists and medical doctors. For example, in Dragonfly Cafe, it's a casual chat we organize within the Dragonfly, covering topics such as isolation, sharing personal stories. We have it 3 times a week, 7 p.m. European time. And also, I would recommend you to check online for the key opinion leaders in your field. Most of them, especially those who are outgoing, have already organized something. So this one can be a good opportunity for you to see what's going on in the field. I personally found very rewarding to become a mentor. This is, of course, not for everyone, but I think especially for those of us who live alone and who don't have families, it will make you feel that you are valued, appreciated, and needed. And this is some part of which some of us struggle with their mental health daily lives. So this is something which I would definitely recommend. And with this, I'd like to open the floor for discussions or for the question. Please let me know if there's anything in your mind.
Thank you very much, Olga. Very interesting presentation with a lot of tips for PhD students and trainees. We have no questions from the audience yet, so maybe I can start off with one. You gave a lot of practical advice and a lot of things that people can take home, I guess. If there's one thing that is the most important thing that you want PhD students or trainees to remember and to take home into their own life, what would be the most important thing?
You understand that you're not alone. Our mental health diseases, I'm pretty sure that the speaker after me will talk about it. They make us feel, they trick us to feel that we're all alone in the world, that our problems are so existential that no serotonin reuptake inhibitor can help us, no therapy can help us, this is not true. There are people who are struggling with the same or similar issues. And I would like everyone to understand that you're not alone in this situation. We're all in that situation. So it's better to share and better to reach out for help.
I think that's a very good tip.
May I ask something? You talk about this fight or flight. I really like it. What does it really mean? Fight we can understand, but flight, because you didn't talk about, does it mean drugs, alcohol, or any kind of this?
I mean, of course, escapism, behavioral, and when it comes to especially to isolation. There's been reports that unfortunately the substance abuse is increasing, and of course this can be like one of the flight responses can be alcohol, excessive alcohol or drug consumption. We try to destigmatize it as much as possible. Of course, it's clear that people who tend to go to the abuse or extensive use of substances, they're struggling a lot. And that when it comes to the things which we discussed with Valentine, it's yet another reason to reach out to help. If you notice that there are some changes in your daily routine when it comes to alcohol or other substances, including nicotine as well, it's definitely a reason to check out. I have a friend who has issues with this, so we have created a small Google Doc form for him where he checks whenever he wants, daily or weekly, the consumption of like mood changes, and including that the consumption of substances and alcohol. And so if you want, you can track whether it's difficult to see, like, 1 glass a day or 2 glasses a day. It's difficult to really track it, especially if you're living alone and if there's no feedback from your family members. So I would strongly recommend to make a sort of a small note somewhere on how much you're consuming, and then think whether it's normal for you or not. And if it's not, then try to reach out for help.
Thank you. Well, thank you very much. That was very interesting. I hope everyone will take some of the tips for himself or herself in the future, and we will invite you again. So now we'll have our last speaker. Dr. Stefan Weibesal, I hope I pronounce it well. Stefan, Professor Weibesal is Professor of Business Psychology at the private University of Applied Science, Göttingen. So his expertise in psychology is a little bit different from what we do or what we learn. But that will be very interesting to hear what you think about us as care professionals. Well, thank you very much for being with us, and we're listening to you.
Well, thank you very much for the introduction. And yes, I hope I can bring something to the table here. In fact, I brought a message with me, and I want to deliver a message here. And I think it's so important that I put it straight away here as the first thing of my talk. As far as I can see, healthcare professionals are really in need of better psychological support. And that refers to both individual and organizational level. And well, that's the message. And if you listen to my talk, then you might understand the reasoning behind that. Don't know, maybe you still can remember those good old days in the first wave. People were clapping their hands. They were giving applause to the heroes, to the healthcare workers in ICU, in hospitals, in nursing homes. There was really, not only in Germany, this picture is here from Germany, then in UK, in Spain, all across Europe, we saw this appraisal or appreciation of the work of healthcare workers, healthcare professionals. And at the time, I think there was even kind of a commitment. I like this picture here of that healthcare workers say, yes, well, we take the risk here. It's okay. You stay at home and you do your part. We do our part to keep the system running, because that's probably the most important thing here, that acknowledged as systemically important. Hospitals must not collapse, and so healthcare workers really play an important role, as you know. Now, I think this agreement has really faded since, and the appreciation of the work of healthcare workers has faded. And nevertheless, the situation still continues. And so I want to present some data here that outlines the current situation, the mental health of healthcare staff. Back in April last year, we were wondering, are healthcare workers really that stressed? At least in Germany, the situation wasn't that bad. Hospitals didn't really reach their capacity level, and so we were wondering, are they really that stressed? And we wanted to explore the perspective of healthcare workers. And yeah, I'll give you some data on that. Are they stressed? We conducted this survey. We've seen a lot of surveys today, but we conducted yet another survey, cross-sectional online questionnaire with 300 participants. Participants from different areas of the health sector. Most of them were in inpatient nursing care, elder care, but there were doctors, there were physical therapists, social workers. This happened back in May and July 2020. Most of the respondents were female, as you would expect. Nursing is really a female profession. So we were asking, what affects your work? What affects you at work on a scale from 0 to 4? What are the barriers that you encounter day by day? And obviously the protective measures came up. They hinder patient contact. It's not great to work with gloves and face masks and shields and whatever. Also, these measures hinder work processes. We've heard that today as well, lots of work processes, procedures changed, and you have to adhere to new processes again and again. Those who had children also told us that the childcare was a problem, and lots of the participants were also afraid of infection of family members, not so much about infection of their own, really about infection of other family members, that they would bring the virus from work to the household. But well, we explored not only those barriers, but even more important, we explored the mental health of the participants. We used a validated instrument. It's called ISR, ICD-10 symptom rating scale. These are 29 items that refer to ICD-10 symptoms. Some examples here, for example, here, anxiety. I suffer from unexplained panic attacks. So these are really symptoms that, or you wouldn't endorse this item if you just have a bad day. These are serious mental disorders. And we've chosen this instrument because it allowed us to make interesting comparisons. We had data from how clinical population as well as the general population responded to that instrument before the pandemic. But also, by coincidence, we had a large sample that was taken during the pandemic in April and May from the general population. And so this allows us really to compare our results, our healthcare workers, to the general population during the pandemic. Here are some of the results. For example, anxiety. As you would expect, just a second here, I need to switch something. As you would expect, the clinical population showed medium and severe level of symptoms for anxiety, while the general population before the pandemic had rather low levels. And now, during the pandemic, there was already, we were aware that there's a significant increase. Here, this is about double the level of medium and severe symptoms of anxiety. And our healthcare professionals, what did they do? Well, they displayed even more, almost double the already increased level of medium and severe symptoms of anxiety. That's, I think, concerning. And same for depression. Again, low levels before the pandemic, significantly increased levels of depression symptoms during the pandemic, and the healthcare professionals showed a total of like 34% prevalence of depression. And that's really concerning, I think. What do the healthcare workers say themselves? How do they perceive the situation? We also conducted interviews, but one thing that I want to share here is an account, like a testimonial. I received that just last week from a nurse working in a nursing home in Germany, and she heard about our research and approached me, sending me this experience report that I want to share with you. She says, "We mastered the first corona wave in spring 2020 well. Then in December, we had the first outbreak. It started innocuous enough with just 2 infected residents, 2 employees. A wide range of measures were implemented to stop the virus. So they brought in this isolation ward. They moved residents within the building, no visitors, all the whole shebang. And 2 weeks later, then it was obvious that the virus was still ahead of us when 2/3 of residents and the majority of employees tested positive. And then turmoil really started. The isolation ward ran out of capacity. So complete nursing home was quarantined. At Christmas, the number of quarantined employees was so high that freelancers and army staff, the Bundeswehr, were brought in for support. It was depressing to see the seriously ill residents. It felt like I cannot look after them adequately. Also, residents struggled to adapt to new staff. Established processes were turned upside down and chaos arose in places. Really concerning. Names and medications were mixed up. It felt like war. That's her words. Next, I tested positive, and then she goes on to report about her illness and also coming back to her workplace afterwards and how it felt. So I don't know, you might say this is just one account, and it's not scientific evidence. But if you look at the literature, it's really concerning. I brought here a meta-analysis just published recently. Systematic review of 93 studies covering a total of 93,000 participants, all about mental health of healthcare workers and nurses. And what we see across all those studies is like 37% prevalence of anxiety across those studies and 35% of depression among nurses across those studies. That's concerning enough. But then we also went on to ask, are you looking for help? So we asked, would you like psychological support to deal with the crisis situation? And here we separated out. Here they are labeled not in need. These are people who didn't show any symptoms, and that's okay. They responded, no, I don't really need help. But even those who showed symptoms, out of those 60% still said, no, I don't need help, or they would say, no, others need that help really more urgently than I do. I won't seek help. 60%. So, in fact, that's not really a new thing. It's not specific to this pandemic, but we saw that even before the pandemic, that help seeking is not really popular in the health sector. Maybe surprisingly, we think that the reason is that healthcare workers identify themselves as caregivers. Caregivers are strong people. Caregivers provide help. They don't seek help. And so this role identity really clashes with the idea of seeking help, looking for help, asking for help. And there's also a lot of self-stigmatization going on. People feel embarrassed about admitting that they need help. They at least believe that they might be frowned upon, or that they just embarrass themselves if they look for help. So that's worrying, isn't it? People obviously do need help, but they don't look for help. What can we do? Well, the good news is that there is actually really established prevention programs. There's really well-known and tested intervention strategies. This is not new. We have experience from previous outbreaks, like from SARS or from Ebola. In previous years, there's best practice from organizational psychology. Communication seems to be key. Clear and timely communication, social support, mainly peer support, so provide opportunities that staff can exchange even formally in a formal way. The exchange should be informal, but establish that they can support each other, exchange. There are established prevention programs that you can use and introduce. Even simple things, as we just heard from Olga, having breaks and opportunities, as well as proper space, proper room for breaks would help. This is on an organizational level. I would also argue for the individual level, strengthen the staff members themselves. So increase their resilience, reduce stigma. It might help to educate them about mental health, about giving them information, providing information on mental health. Also bring in support services, as in there might be this helpline, there might be counselors available, therapy available to staff. So yes, there are ways, and we even try to condense this into a checklist for senior staff that you might want to download. I'll show the link in the end again. So just to summarize, healthcare workers are not in a great situation at the moment. It's maybe not be that surprising, but the numbers, the sheer numbers in the end did surprise me. And I find it worrying that they tend not to seek help. So we really need to do something about this. We need to provide intervention strategies, prevention programs. We need to help this particular group. You might be directly involved, I don't know, or maybe you have ways of supporting this issue. At the moment, just very briefly, we do a second assessment. We want to see how did it change since last year. That's running right now. We already have 650 responses. And this time we look at Germany, Austria, and Switzerland. And we also have a project going on help seeking, how to encourage more help seeking behavior. Yeah, that's basically it. Here's the link for the checklist again.
Well, thank you very much. I mean, we're not seeking for help, but we invited you and Olga, and so I'm sure now we have to do something. And no, it's very interesting, and as you say, far from us. So we have one question.
Yeah, we did look at gender, and we did look not at professions, but at age. Within our sample, we couldn't really see significant differences. The sample is not that big with 300 participants, so there may be differences, but they are not as obvious, not as strong as you might expect. Not even the gender difference, which you would expect for depression.
And so we have one question. Well, I don't see it. Where is it?
I think it was just answered. the question.
Yeah, I referred to that question. Yeah.
Okay.
Yeah.
Okay. Are there any questions among speakers?
If there's time, I have one question. The numbers you showed, they look really troubling. Really high percentage of healthcare workers with depression. So if we now move into a different time with vaccination and we go back to normal again, how long do you think these effects will actually last?
Well, that's probably the really big question here. We don't know. I would expect that we see rising levels of post-traumatic stress syndrome, PTSD, with this ongoing situation. Even, I mean, it won't go away immediately, and so I think the situation in hospitals will remain difficult for quite a while, and this continued stress level is really a problem. After that, anxiety, I hope, will go down again, and also depression might be not as bad, and there are treatments available. That is really not so much the issue, but more that this particular group doesn't really want help, and I think this is what worries me. What can we do about the help seeking?
Yeah, does the depression can become a decrease in, I mean, in trainees, in training to become medical doctor or nurse? Because people will say, no, I don't want to become this or this.
Yeah, I'm not sure what is involved in the training at the moment, how much mental health education, mental health hygiene is told or included in any curricula, but I'm sure it is a good idea. This, as I said, it's not new. We knew that help seeking is low, and I can fully understand the reasons behind it. It is probably difficult to do this big step forward and admit that you have an issue.
Well, thank you very much for coming with us. And now I will let the floor to our president of ESCMID, Maurizio Sanguinetti, and Valentin. You will introduce Maurizio.
Yeah, it's my pleasure to introduce the last speaker, Professor Maurizio Sanguinetti. He is a professor in microbiology, working in Rome, Italy, and also our current president of ESCMID. And Maurizio will provide us with some closing remarks and discussion. So please, the floor is yours.
Thank you so much, Valentin. Thank you so much to Emmanuel, first of all, to organizing this very nice webinar. I think that this was very important, either for the program of the webinar, because we had to discuss about us, so about the role we had and we have, because the story is not finished, in this very dramatic situation. So, and it's very important also to add this part on the mental impact of this situation on this on our lives. So I think that this event, this webinar was absolutely interesting. In particular, was depicted a complete picture about the reaction of ID and CM to the pandemic, and also about the role of trainees. This is very important, at least in my personal experience. We did a lot of work, as all the microbiologists, of course, in Europe and in the world, but without trainees, it was impossible to make all the work we did. This is very important. We try to maintain the track of the trainees, but I think that it was quite difficult because all us as microbiologists and ID was completely stressed about the situation. So we try at least in my lab to maintain the rotation and all the normal life, but this was very difficult. We had to underline this also because all the trainees involved in this experience more or less from some point of view lost a year, because this is important to note. From other point of view, this year was very, very, very useful because I hope this was the last time, but to interact with the pandemic was really something very unusual, and this is very important to underline. So hearing all the presentations, I had two different thoughts. The first, and I think that Emmanuel had the same idea from me. The first thought regarding clinical microbiologists, because this is probably an issue about all the strategy put in place in Europe, and in particular in Italy, is the role of the microbiologist in this story. Because probably our role was not so very well stressed. I think this is important because several other professionals have been involved in diagnostics. I don't agree with this. I know that we are an emergency, but I think that this could be also a possibility to improve better the microbiology network across Europe. Of course, this is a provocation, more or less, sorry, but I think we have to discuss about this, and it should be fantastic if you can report our thought, Valentin, all the speaker, about this point. Sorry, this is really microbiology oriented, but for ID, the story is different. So at least in Italy, all persons are involved in diagnostics, a pharmacist, general practitioner. So probably we have to think about this, because this could be dangerous for the future, because for our profession, we are professionals, we are an important culture in this, and we have to discuss about this. The second one regarding health, mental health, because my question to all you is, there were some helps in your hospital from this point of view, because at least for me, this year was really terrific, because I had some depression on myself also, and it was very difficult. And also the persons in the lab, and also my friend, ID friends, had some problems. So the idea is, my question is, in your opinion, there was a good support from the health point of view for all the persons involved in this pandemic? And I think that we have to think about this, because the story is not finished. So we have to, I don't know if you have any idea about this. Finally, regarding all the surveys presented, I think that we obtained some interesting results. For instance, as cancer presented, there are some prophylaxis used in the first wave, prophylaxis with azithromycin and hydroxychloroquine, and the following studies, the following trials underline that this type of approach is completely wrong. So this is very important. These surveys are very important, in my opinion, because we can learn from our normal survey mistakes, because it's possible to make mistakes. This is absolutely a dramatic situation, so it's possible to make mistakes, but it's very important to learn from our mistakes. And these surveys presented are very useful from this point of view. I don't know if you think to publish something, but I think this could be very useful. So these are my thoughts about this webinar, and I have really to congratulate all the organizers. First of all, Emmanuel, for sure, Ben, for sure, all the speakers, all the chairs, because this was, for me at least, a very, very useful and interesting event. So if someone want to reply or to discuss this point I raised, I would be very, very happy.
Yeah, is there any other questions or comments on what was said? Maybe I will say something about seeking for help, because Stefan say usually healthcare workers are not seeking for help, but who will give the help? Because I think for
Exactly.
all of us, hospital directors or governments, I'm not sure they are giving this help if we ask for help. So maybe this is some sort like resilience, that we are not asking for help because we know we will not get any help. I don't know, it's a little bit provocative, but I wonder if any of you had received any help.
Not from my side. For this, I raised this question.
Valentin, you want to say something?
Yeah, I think it probably also depends on your country and your situation. At least in the Netherlands and in my hospital, there are networks for this to provide help if it's needed. But I'm curious to hear others' opinions and experiences about this.
Maybe I can add something regarding Turkey. We have a Society for Infectious Diseases and Clinical Microbiology, which is called CLIMIC. And our society took this, took the lead to provide some professional support regarding mental health to all the physicians. I mean, it was really easy to reach this support from the society. Not because it was not so, Turkey is a huge country, maybe it was not possible to create such a network, I mean, all over the country, but our society took a great lead and role in this matter.
Thank you, Shamsu. Other comments or other questions? So, Stefan, who will give the help?
Yeah, well, I have a German perspective here, obviously, and so I think the background is that the whole thing with this questionnaire started when two psychologists approached me, and they set up this helpline, especially for healthcare workers, telephone helpline. They trained psychologists to provide counseling on the phone, and then they publicized this. They even marketed it in some way, and nobody called. Not nobody, but the uptake was really slow. And and there's another provider, another helpline, if you like, in Germany, also available. And so I don't know about other countries, but at least here in Germany, there is help available.
Yeah, Dragonfly.
Yeah.
I'd like to add, I'd just like to add that I absolutely agree with Stefan, and thank you so much for bringing it up. I think in this case, and especially in the case of the shortage of resources worldwide, we really need to promote peer-to-peer networks. Peer-to-peer support networks are the key at the moment, which, while not being exactly like not being 100% professional, but still among us as medical professionals, this peer-to-peer networks can be really, really helpful. The same goes for PhD students. The same goes for the trainees. The only problem I'd say with the peer-to-peer networks is that it always requires someone who really cares. So one person who cares in one taken, like a separately taken institute can create the whole program if needed, but at least one person should be there. And then peer support networks have shown, and it's been published, that they do really help.
Well, thank you very much. I think we have to close it, but so it may go on with the TAE network, with the ESCMID Professional Affairs Network, and ESCMID as a whole. Thank you very much, all of you, again, for your speech. So they will be recorded as a YouTube or e-library. So if there is anything against, then you will write to us. And thank you very much again. And so be careful.
Yes.
Thank you. Bye.
Thank you. Bye.
Thank
Take
you.
care.
Bye.
Bye.
Thank you.
Bye.
Bye bye.
Bye.
Ciao ciao.
Bye.